medicine and infectious and has done a degree of infectious disease from University of Florida, Tampa, which is one of the largest transplant center in the United States. Over to Dr. Dhanashree Kelkar.
Thank you for the introduction. At the outset, I would like to thank the hepatobiliary team for inviting me to be a part of this symposium. And no, this is not a sponsored drug talk. Unfortunately, Pfizer happened to show their video about anadurafungin right before my talk. The objective of this talk is basically in 15 minutes, I have to give you a brief overview of something which would be a 2-day symposium. So in my talk, I would include the impact of infections on acute liver failure, give you a brief introduction to the spectrum of infections in acute liver failure and the development of preventive strategies to prevent infections. In addition, I would also like to touch about evidence-based approach to prevent the emergence of multi-drug resistant organisms in acute liver failure. Now, why is it that we are all concerned about infection and acute liver failure? As Dr. Soin and Dr. Rela already emphasized, infection is going to initiate SIRS, it's going to initiate multi-organ system failure and ARDS, and in all, it's going to worsen mortality for acute liver failure. In addition to worsening your mortality, it is going to worsen your encephalopathy, it will worsen the cerebral edema, and it will preclude patients from going for a liver transplantation. This study by Tsai M and Chen showed that only 1 in 20 patients with acute liver failure and septic shock actually survived to leave the hospital. So that means you have just a 5% survival rate for patients who develop septic shock in acute liver failure. 80% of patients with acute liver failure have been shown to have bacterial infections. Now, these studies were much earlier, they were in the 1990s, but still somehow the figures haven't changed. But up to 25% of patients with bacterial infections also develop bacteremia. And this bacteremia is again going to lead to sepsis and SIRS as well as sepsis later on. 25% of patients with acute liver failure and infections were actually excluded from getting liver transplantation. And of course, infections have known to cause about approximately 40% of deaths because of post-transplantation. Now, whenever I come across an infection in a patient with acute liver failure, it's important for me to know. For me, everything is infection and otherwise. So it's important for me to know whether this etiology of the acute liver failure is infection induced or associated, because I know that other humoral immune systems and complement activation has already taken place, or whether there are other causes of acute liver failure. Everyone has already touched upon the infectious causes of acute liver failure in viruses. In addition, I would like to add adenovirus and parvo B19, which even from India, there are case reports that these have known to cause acute liver failure. In India, the other case that we see is dengue. Dengue is known to cause fulminant hepatic failure, and there have been case reports about that. Bacillus cereus food poisoning, leptospirosis, which is not uncommon in India, E. coli sepsis, especially in neonates, as well as syphilis, a disease which we thought we had nearly eradicated with the use of penicillin, is still known to cause hepatic failure, especially in the secondary syphilis phase. Now, with hepatic failure, you can have infections from all possible points. You can have bacterial, fungal, viral, even prion diseases have been reported, though not commonly in acute liver failure. But which infection is going to occur in which group of patients would actually depend upon the portal of entry. So the portal of entry would be either device associated or non-device associated. The reason why we have so many invasive monitoring in patients with acute liver failure is that we are going to have a large number of device-associated infections, either as central line-associated bloodstream infections or catheter-associated UTIs or VAPs or even ICP-related monitoring-related device infections. The non-device-related infections occur either because of translocation from the gut. Patients with hepatic dysfunction are going to translocate bacteria from the gut, or there's an inherent immune dysfunction. Inherent immune dysfunction will be because of neutrophil activation, and if the liver is also not functioning, complement activation is also going to be a problem. Thirdly, we should also not forget about reactivation of diseases. So a patient was already harboring a disease like, say, tuberculosis, patient was getting treated for it, developed acute liver failure, and he's going to worsen his tuberculosis also with this. Now, why is the etiology of acute liver failure also important in the case of finding out which kind of infections? Like if you have drugs and toxins like isoniazid, nevirapine, or efavirenz, you want to know, that the underlying liver disease infection like TB as well as HIV is also going to worsen in these patients. So you have to keep in mind diseases related to both of this. In addition, if you have an acute liver failure on chronic liver failure, what we use an acronym called LIVA, these microorganisms, Listeria, Yersinia, Vibrio, and Aeromonas, are known to cause fulminant shock and death in these patients. So you want to know whether the patient had some amount of chronic liver disease before getting acute liver failure. If it is a hematological malignancy associated acute liver failure, you have to think about fungal infections belonging to the group Mucorales, that is mucormycosis, because all these patients are going to have iron overload and going to have mucormycosis infections. Patient who have liver failure associated with trauma and liver injury are going to have the soil organisms, especially Pseudomonas, Clostridium associated with it. If you have a post-transplant associated acute liver failure, you want to think Aspergillus, very commonly seen in post-transplant group of population, as well as you have reactivation of various viruses like CMV, EBV, which is also going to play a role in this. If you have ischemia-associated acute liver failure, you have to think translocation from the gut, so all the Enterobacteriaceae, which are going to form the major group of infections in these patients. In addition to what is the cause of acute liver failure, you also have to take into account the coexisting factors, whether the patient is on immune suppressants, if a patient has been on steroids before, the types of diseases or opportunistic infections you're going to see in these patients are different, or if the patient is pregnant, because drugs you want to give it in a patient who's pregnant may not always be classified safe for the infant. In addition, pediatric population will have a different subset of diseases which are involved. Now, whenever we look at an infection, we always, as clinicians, we want to look at clinical evidence of infection. Unfortunately, in acute liver failure, everything that acute liver failure is going to can look like an infection. So we cannot really go depending only on clinical parameters per se. But if the patient did not have these parameters, you can always go by these. Fever, tachycardia, hypotension, bradycardia, or even worsening encephalopathy all point towards infections. Everything that we are going to look at for lab evidence is for infection. You are going to have leukocytosis or leukopenia, which can be a part of your SIRS itself and as a part of acute liver failure. You can have thrombocytopenia. Occasionally, a patient who was thrombocytopenic starts developing thrombocytosis. That means he or she is harboring an underlying infection, and that can occasionally point towards it. In addition, you have to do cultures, either the urine, the bowel, if the patient is intubated. You want to do blood cultures, aerobic, anaerobic, fungal, mycobacterial. Now, two things I have not included in this is procalcitonin. One is procalcitonin because currently there are no studies proving or disproving the use of procalcitonin in acute liver failure. In addition, there are no studies about procalcitonin in immune suppressed population either, or in pregnant population or in the pediatric population. So I would not say that procalcitonin is a test which I would go by in diagnosing infections with acute liver failure, at least till we have more further evidence. In addition to cultures, we also want to do viral studies. IgM, IgG antibodies would probably not have a role in this stage, but yes, your nucleic acid assays as well as PCR is what we would look at for evidence of infection. Once you find evidence of infection, obviously you're going to treat it. Every hospital has their own choice of antimicrobials depending upon what the antibiotic program says, as well as what your current flora is. But early on during an infection, you want to think Staphylococcus, more skin-related, anaerobes, and Enterobacteriaceae, which are more from translocation. But as you go beyond around 7 to 10 days, or you run into 2 weeks, you want to think about hospital-acquired infections. Everything is going to be hospital-acquired at that point in time, and patient is already colonized with MRSA as well as your VRE, including and multi-drug-resistant Pseudomonas, the NDMs, which India has a lot of them, as well as your Acinetobacter. Now, when are you going to cover for fungal infections in these patients? So, fungal infections start occurring once a patient has been on antibiotic. Some people say 5 days, but mostly say 7 to 10 days, and you start running into fungal infections. Or if a patient has been sicker for a long time, has been on antibiotics in and out of the community, you want to start thinking about fungal infections earlier on. In 32% of the patients, you of acute liver failure or candida has been isolated as a cause of fungemia in these patients. Now, just a clinical case which I came across a few months ago, and this is from India itself. There was a 17-year-old female with acute liver failure, unknown cause, was treated with piperacillin tazobactam at an outside place for 5 days at a peripheral unit, and then was transferred to a tertiary care unit, where she continued to have fevers. Blood cultures were sent, patient was started on appropriate antimicrobials, doripenem, cipro, teicoplanin, and fluconazole. You're covering gram positives, gram negatives, and all your cultures are negative. A patient worsens on day 5, has shock and renal failure, and all cultures still remain negative, and the patient ends up dying. So what is it that you missed, or what is it that was missed in this patient? Is, yes, you can think about NDMs in these patients. Okay, maybe the patient should have been on colistin, but if you do adequate cultures, you really do not miss out on them. It's most of the times that we miss out on organisms, bacteria causing infections, is because we are inadequately culturing these patients. You have to think fungal. Fungal cultures is something which was not actually sent for the patient, and you have to think about azole-resistant candida. Okay, there are certain species of candida which are not going to be susceptible to your fluconazole or voriconazole, and in these patients, if the patient starts deteriorating on an azole, you want to shift these patients to echinocandins, either anodula fungin or possibly micafungin. Or you can add liposomal amphotericin B, which also would cover your azole-resistant candida. So this is something which everyone needs to keep in mind, that if you are having a patient who's deteriorating in spite of putting the best of antibiotics and azoles, you want to think about resistant candida. Certain other experimental therapies are also used. I have not seen them being used in India, but I have seen it being used otherwise. Or what they have used is a polymyxin B hemoperfusion based treatment in combination with MARS. MARS, they're going to speak about tomorrow, has been used to treat patients with endotoxemia. Now, what they did in this group of patients was they did an endotoxin assay, and polymyxin B is supposed to basically absorb the endotoxin, and that is why they have been using this system. Now, this has shown to work in a few cases. There are not many cases as yet in literature, and that this is not something which is easily available. Now, in knowing how to treat an infection, you want to first also know how to prevent an infection. Primary prevention is the most important role it is going to play in your liver ICU, your medical ICU, your surgical ICU, wherever your patient is, be your patient being in the ward. Most important is going to be a high quality infection prevention team and high quality infection prevention methods which have to be in place for any patient with acute liver failure. In addition, when the patient is admitted, we do advocate that you do a MRSA screen and a VRE screen, because in case the patient starts getting sicker, you want to use the right antibiotics by knowing these organisms beforehand. Now, gut decontamination. There is still a questionable role of gut decontamination in ALF. There are studies which have shown that, okay, gut decontamination for patients who are in the ICU has decreased the amount of infections, but these studies have not really shown any survival benefit. So whether to do gut decontamination where we don't have any survival benefit, we still do not advocate that. In addition, gut decontamination, what antibiotics you're going to use to clear the organisms, microorganisms from the gut, are also going to kill the microorganisms which generate glutarate, which is basically the food for your colonocytes. So you're going to enjoy your colonocytes in that. Lastly, the role of prophylactic antibiotics. The current ASSLD recommendation says that prophylactic antibiotics and antifungals may be considered, but have not been shown to have any improved overall outcomes in these patients. So again, they've got a class 2 recommendation and a class 3 recommendation. Similarly, they have also advocated that you should do periodic surveillance cultures, should be performed early to detect bacterial and fungal infections. Now, if you look at these, both of them have similar classifications. Both are class 2 and class 3. However, if you give antibiotics and antifungals to a patient, you are going to develop multi-drug resistant organisms. So when the patient actually gets an infection, you're not going to be left with much to treat it. Especially if you get a gram negative, only thing you will be able to use is colistin. You cannot use tigecycline with acute liver failure. You cannot use chloramphenicol, what people try. So you will not be left with much choices if you start doing prophylactic antibiotics. Whereas surveillance cultures, you don't have a problem, you're not causing any side effect to the patient, in a way you're actually monitoring regularly. So just the take-home message for this would be, you need to have a high-quality infection prevention program there. You can do daily surveillance cultures for the blood, urine, and sputum, and daily, if not daily, at least alternate day, and more frequently. You have to keep a high index of bacterial and fungal infections in mind. And as soon as you think of infection, you want to start them on preemptive antibiotics. And you need to consider antifungal therapy, especially when the patient is worsening on bacterial coverage. Thank you.
Thank you, Dr. Kelkar, for an excellent talk. Now the floor is open for discussion. If you have any questions, please.
Can I ask you one question?
Sure.
The ASLD recommends the periodic cultures for the bacteria and the fungal.
Yes.
Do you have any data? What is the impact of these periodic cultures on the outcome in the ALF? As far as the infection is concerned, or the ultimate survival benefit is concerned?
No, I don't have data on survival benefit for that. But yes, as far as infection is concerned, the ASSLD, what data they evaluated was that if you do periodic cultures, you're likely to pick up infections faster, diagnose infections faster. That's the only data they have. So that is why it still has a grade class 2. It's not a class 1 indication.
As far as the Indian context is concerned, in the last, say, 8 or 10 years, what has changed as far as infection control, sensitivity of antibiotics, or the kind of bacteria that you are growing in your cultures? What has changed, and is it for the better or for the worse?
Actually, what has changed is that we are growing resistant organisms from community patients. Patients with community-acquired UTIs have resistant organisms, ESBL as well as NDM. So it has changed. The flora is now more resistant, and it is worse. Worse for us, as we don't have any more drugs in the pipeline, and worse for the patients also, because they are going to be stuck with resistant organisms. So the flora has changed in that way. As far as infection prevention, yes, we advocate universal. Before, it was universal precautions only for patients who have either transmissible diseases like HIV or hepatitis B. But now we advocate universal precautions for every patient that you come in contact with. And infection prevention is getting more and more, it is getting more and more intense as to try and preventing infections from transmitting patient to patient in the hospital, physician to patient, as well as physician to patient to physician. So in that way, infection prevention is getting higher.
Dr. Dhanashree,
Last question.
Just a couple of doubts. One is regarding surveillance for MRSA and VRE. Can you please elaborate on that? Second aspect is when you decide to go about treating for fungi, what would be your first choice? Would you directly go for the newer ones, or start with the fluconazole or something simpler?
Okay. Regarding the first questions for MRSA and VRE screening, now we generally advocate that any patient who comes into the ICU, we should do an MRSA screen, because we know whether the patient is colonized with methicillin-resistant Staph aureus to begin with. Because if this patient gets an infection, you don't want to put, you want to put something which has MRSA coverage, like either vancomycin, teicoplanin, or be it your daptomycin or linezolid to begin with. VRE also, Enterococcus is a part of our gut, and it is known to translocate. So if you are colonized with VRE, if you put a patient on vancomycin, it is going to be of no use for these patients. So in those patients, you want to use different antibiotics like either linezolid or daptomycin. So that is the reason why we advocate for screening for both of these, because your preemptive antibiotic choice will depend on that, whether a patient is colonized or no. About the second question about antifungal coverage, if a patient has not received an azole before, yes, fluconazole would still be the first drug of choice. But if the patient has been on azoles before, or has been on antibiotics for a long period of time, or has grown resistant candida from the urine, not necessarily an infection, but even been colonized with a resistant candida, you would want to use either echinocandins or amphotericin in these patients.